Good morning. Thank you for joining Lighthouse today and Affectiva. Today we're going to be doing a product talk about how we are beginning to integrate the Affectiva functionality into our patient care plans. Ask me any questions and we can answer them on the fly. So let's dig right in. Lighthouse, very simply, helps people living with chronic diseases build great habits. We work with patients between their doctor appointments to help follow the doctor care plan. We hear from physicians that patients aren't motivated to follow the care plans that they receive, but what we hear from patients is, my doctor is great at telling me what to do, and she's terrible at telling me how to do it. And that's where we step in. Our service is a combination of software that integrates into the electronic medical record software inside the doctor's office. We also have a patient-facing application focused on helping the patient build core skills in diet, physical activity, taking their meds, and writing things down. We also have a nursing team that calls the patients each month to help them navigate their plan and build good habits. And finally, we have a web-based portal that allows anyone in the patient's care team to have access to the full health record. The application is the patient-facing mobile application gives the patient access to their complete health record and also the care plan that the physician has developed for them, as well as content to slowly help them build their core habits. But for anyone who works in healthcare, you know that really the heart of care and where the greatest impact is made is from humans, and more specifically our nursing team. So we've begun to integrate Affectiva into our patient-nurse interaction. Today, each patient gets somewhere between 20 and 40 minutes of phone support to help them translate their great doctor instruction into healthy patient action. And we've begun to integrate Affectiva into a pilot we're doing for mobile calls from the nurses, or video calls from the nurses. So why do we care about the emotions and the sentiment of our patients and the great functionality and sentiment that Affectiva can surface for us? One part is pretty simple. More than 60% of primary care visits have stress as one of the core drivers for seniors. And stress can accelerate dementia, increase blood pressure, impact digestion. That fourth circle there is a pancreas. It can accelerate the onset of diabetes and wreak havoc on your bowels. It is a very underdiagnosed and treated condition, but as a caregiver becomes aware of it, they can change their interaction style. Now, just to give an idea of the order of magnitude of the conditions we're trying to drive good behavior around, I think collectively we've got, somewhere around, $1.2 trillion here of conditions that we're trying to help patients form good habits in their treatment of. Additionally, patients not taking their medicine as prescribed drives an additional $200 billion in healthcare costs in the United States. So this isn't the cost of I didn't go and pay for my medicine. This is the secondary implication of an extra trip to the hospital or an advance in my condition, every year is another $200 billion. The way that our nurses interact with our patients is they are largely home-based nurses that on their own schedule sit down in front of their computer and are given a list of patients to call and what the goals of that patient call are. Historically, these have been just voice calls where the nurse might walk you through your healthcare plan again, check to see if you've re-upped on your meds, confirm that you went and had that podiatrist exam, and to try to get a sense of how can we make more impact, we are piloting video calls, both to see if there is a subset of patients that are more receptive to that protocol, and also the physician can charge Medicare in a different way and give qualified care to different groups of patients if we do a video call and not just a voice call. So what we're doing in our pilot is when we do a video call, in real time, we process the video feed to try and surface sentiment and anxiety and stress from the patient in order to inform the priorities of the call for the nurse. So for example, if today's call was largely centered around for the patient, are you doing the things that we hope you're doing? And if during the course of the call, the Affectiva signal begins to suggest that the person is becoming more stressed or frightened, then the nurse will change the priorities for the call to try to understand what's giving the patient anxiety. A typical example would be you're talking to a patient about the beginnings of their physical activity plan and they become increasingly agitated. You stop the script and just engage the patient with something as simple as, how are you doing? How is diabetes or how is hypertension impacting your life this week? And now we aggregate all the signal from Affectiva up into a green, yellow, and red. We take the full signal and we set thresholds against some of the indicators and against variability. We're still fine-tuning exactly where those thresholds are and additional factors we need to incorporate based on kind of the age and the brightness and the nationality of our patient to make sure that we're getting an accurate read from the patient. Really what's going on in this call is we're using the Affectiva feed to take in the information. We've narrowed down the relevant signals from the Affectiva feed to a subset of, as you see on the screen, fear and surprise, how engaged they are. Valence is like another word for variability, how things are changing during the session. Brow furrow, we get a good signal on, and eyes closed. We combine these into a composite score that drives the green, yellow, and red of our signal and informs the nurse against the discussion. So today, we are using Affectiva to get a real-time, high-level signal in the middle of the call in order to potentially inform changing the script and the goals of the discussion. In the future, We collect all of the signal and save it against the patient, and over time we'll be able to match that against changes in behaviors and changes in outcomes so that we can have a more refined red, yellow, and green signal from the patient, and then also begin to understand for cohorts of our patients which of the signals are just the nature of having medical discussions and which signals are indicators in kind of lack of receptivity or unlikelihood of changing behavior. So that's where we are right now. We've completed about 37 calls and processed the signal. In those calls, 18 of them generated a yellow or generated a red signal that caused us to change the course of the discussion. It's only been 2 months, so there hasn't been enough time yet to understand changes in outcomes for those groups. And we continue to refine the model around how we aggregate the score to generate the red, yellow, and green. And that is what we're doing with Affectiva. It's a web-based experience for the caregiver. So I think we're using the HTML5 or the JavaScript implementation. And that is what we're doing. Any questions on what we're doing or how we aggregate the signal, or any ideas from the audience on how we might translate the Affectiva signal for bigger impact?
Hi, Dave. Hi, Dave. This is Rana El-Kayoubi. I'm co-founder and CEO of Affectiva. It's a pleasure to have you and hear how you're integrating our technology within Lighthouse. I have a few questions for you while we wait for other questions to come in.
Great.
So my first question is around changes in outcomes. What kind of outcomes are you looking for?
So
how do you assess those?
We work mostly with seniors and address kind of the big gorillas in chronic care, which are diabetes, heart conditions like hypertension or high cholesterol, and COPD, which used to be called emphysema, and it's just difficulty of breathing. Each of those have got indicators of either blood sugar level or blood pressure or weight or amount of weekly physical activity that studies know how those all tie back up to eventual overall health for the patient. And so we'll know if a priority for a patient is a 5% reduction in body weight, we'll be able to match the Affectiva signal to similar cohorts of patients with similar goals and begin to triangulate if there was an emotion signal in our video calls that indicated that someone said, yes, I'm going to start walking around the block once a day, and that doesn't end up happening, or it does end up happening. We're looking for both positive and negative signals.
And then another question, how do you aggregate the different facial expressions to come up with a yellow, green, and red score?
So we're when we did our first 10 interviews, we looked at the full set of signal from Affectiva and eliminated the ones that were correlative, that kind of all moved together. Then we work with behavioral health providers like the Diabetes Behavioral Institute to help us understand how our particular group, the emotions that tend to dominate healthcare conversations, and we ran simulations with actors to begin to identify things like furrowed brow was the best indicator of frustration among the signals. For now, we have them slightly weighted towards fear and surprise, because those are the sentiments explained by patients that drive their understanding or willingness to participate in the discussion. And you can imagine that you've just been told you've got serious heart disease, and as the doctor begins to explain the health protocol, all that's going through your mind is, oh my gosh, I've got heart disease. And so we'll continue to refine kind of the weighting of those as we get more information about outcomes.
So another question. Have you thought about building longitudinal emotional profiles for patients so that you can, you over time have a sense of, okay, this is the baseline for this patient, so when they deviate from it, that gets flagged?
Yeah, and we do collect longitudinal data with the hopes of kind of identifying for specific patients if there is a more natural band of emotional activity for them. We found research suggests that some groups exhit anxiety and it doesn't impact their change of behavior, and some of it does. And so we will be trying to build, like I use the exact right word, the baseline at the individual level, so that we don't process every signal the same. And also potentially we can maybe early in a call identify that we're not having a good day, and we might just reschedule for a different day if in the first 5 minutes of a call someone is acting already outside of baseline.
That's great. So we have a question from David Booter. Why do you not use joy or happiness as one of your emotion indicators to determine red, yellow, or green?
We find that joy and happiness is not very often present when people are having discussions with their doctor or caregiver. Before we did any of our interviews to begin building our baseline and normalization formula, we watched a lot of videos of doctors delivering healthcare plans and instructions to patients, and there's not a lot of joy present in that. And also the research suggests that there is more value in identifying lack of receptivity to instruction than benefit from identifying kind of over-receptivity to it, for lack of a better English word. So top on our list is to identify, is this call going bad, so that we can change our script? But if the call is going great, that isn't necessarily information that our nurse needs to change her discussion.
That's great, thank you. We have a question from Temitayo. Temitayo is actually a student at UCL, and she does a lot of work in affective computing looking at pain. So her question is, with the video calls, did you have any ground truth measures, example self-reports of mood, to help you understand how well affects performed for real patients? That's a great question.
Yep, we haven't done any self-reported baseline work yet. I'd say we're still pretty, we've got less than 50 interviews so far, so we're still 15% logistics, getting patients to sit in a well enough lit room and get the technology to work correctly. But I think that's a great idea to, there's a lot of information. Not only is there value in the information of having insight as to what mood or mindset a patient is in, but also how they describe themselves versus the Affectiva measure is also an insight. So yeah, that's a great idea that we ought to include in version 3.
So related actually to that, have you thought at all about measuring pain? Is that something that would be helpful to track?
Yep, so our suspicion right now is that if patients are having a painful or bad day, they don't do the phone call with us. So what we found, especially with some of our acute patients, is that there's a pretty low threshold for them to cancel or postpone our call. And so our suspicion is if there was pain that was impeding the patient, our call would get canceled. So we've thought about it, but have decided to, at least at the beginning, we're building a Honda before we build a Jaguar. So we're starting with a smaller set of measures, just looking for, are you exhibiting kind of the entry-level patient behaviors of afraid or surprised or not paying attention, which are kind of the tier 1 indicators of your care message isn't getting through.
Okay, we have more questions. Is it important to have low stress during the call? If somebody's not following the medication or behavioral advice, he might be nervous while reporting this, and he or she should be. So perhaps this would change his behavior afterwards?
So right now we're using the signal to identify if, to reconcile what the patient is telling us and what their emotions are telling us. In one form, our nurse is kind of like a tracker trying to find out, are you doing good behavior? Typical behavior with a tracker is, first you're excited about it, then you lie to it, then you break up with it. And we're trying to, what we try to do with the signal is, if we're hearing from the patient, I never miss a dose, and we begin to see an uptick in stress or fear or surprise, that will signal to our nurse to ask a couple of additional probing questions. If they're saying, I'm not taking my meds, and they're having that stress, those line up. So we're trying to reconcile what we hear from the patient, what we see in the picture, and the signal that we're getting from Affectiva to inform what are the next 2 or 3 questions that I ask the patient to try to get to the truth and then success in helping them understand their behavior.
That's great. Another question. This one's an interesting one. I'd be curious what you think. From Thomas Nielsen. Do you see the system being programmed so that virtually interactive nurses are facilitating the interviews with patients?
There are a couple of great, interesting virtual AI nurses, like Sensely has got a great one. We find that a lot of our calls go pretty broad outside of the care discussion. A lot of our calls, the first 5 minutes is catching up about grandkids, or it's so great to hear from you again. And we suspect that human nurses are still the best at that. Additionally, at this time, our program is paid for by Medicare, and they say it's got to be humans. So I think if there's a big jump forward in the ability for AI nurses to engage on not just the advice part, but the full relationship that a lot of times a caregiver has with a patient, now that'll be one thing, and we have to go along with the person who pays us, which is Medicare, and for now they say, got to be a human.
Hi, Dave. These are all the public questions that we have. There might be questions privately asked at your end. Would you be able to have a look at the Q&A? from your end?
Yeah, let's see how I find that.
Go up top. There is a options menu.
Yep, I see chat.
There's a Q&A. Now go up, and there's an options drop-down menu.
All right, let's see. I'm looking for the word options here.
Top on the ribbon.
There we go, I got it. Yep. Q&A. All right. Let's see. Let's see. Is it important to have, all right, we just had important as low stress. We did the ground truth question. Yep, I think all the questions have been publicly asked.
I still have a couple for you. Have you thought, so on the topic of kind of human versus virtual nurses, empathy we find is really important in these types of relationships. Have you thought at all about tracking both, kind of tracking rapport, so not just the patient's facial expressions, but maybe the nurse's facial expressions, and coming up with a rapport index or an empathy index?
We haven't, but that sounds like I think we haven't thought at all about kind of taking a take on the nurse, because I think as you can imagine, the facial expressions, or if the nurse seems agitated or surprised or afraid, that will be reflected back, and that might be an additional piece of information that helps us.
We can hear you perfectly now. Can you repeat that?
Yeah, so we haven't done any work yet on taking a signal from the nurses, but I think that's a great idea, since that's a very big input into the mood and feelings of the patient. If it engages you and they seem agitated or afraid or disengaged, that could be what is driving the patient signal, and it would be good to understand that and normalize that out. I think we haven't looked at the Affectiva capability to try to imagine how to construct a rapport index, but that sounds pretty interesting.
Yeah, we'd love to collaborate on that. I think it's something very important, especially as we start to see more of these conversational interfaces. Mm-hmm. Quantifying it and being able to say, okay, you know what, like the rapport index between these two specific individuals is low. Let's either change up what the nurse is doing, or maybe bring in a different nurse, right?
Yep.
Yeah, that's cool. And then, so healthcare is one of the markets that we as a startup are very, very interested in. We do find it hard to navigate. I'm curious about, I mean, if you're willing to share kind of your go-to-market strategy. How do you sell this to hospitals, to clinicians?
We sell to primary care physicians, and we've found that physicians, so we integrate into the electronic medical record, so into Allscripts or Athena Health or Epic. We find that as the more effortless you can become part of the patient-doctor workflow, the higher likelihood for success you have. As soon as you start to try to introduce a change to that workflow, the care team's interest drops off precipitously. So the secret is, or not the secret, but the EMR is in every office, and more is the centerpiece of the management of the information, and also it is the link to how they get paid. And so over time, if you're both trying to become an effortless part of the patient experience and linked in with how you're going to get paid, or how they identify the value you create, I would say put EMR integration high on your list. We focus on independent physicians as opposed to physicians that are a part of a larger health program like a Kaiser, because they more often are in control or have greater say in the care and the programs that are delivered within their office. And also, if there are additional Medicare incentives available, those flow to the doctor, not to the hospital group that owns them.
That's great. That's very helpful. Very helpful. Okay, a final question. What other use cases or applications of emotion AI do you see in healthcare?
Well, so I think the next thing that we're investigating and starting to sketch out is patient-initiated communications or check-ins. So a big financial driver for hospitals right now is the rate at which patients come back into the hospital after a protocol. So the higher the frequency which they come back, insurance company pays that hospital less money. And we're trying to understand, is there some kind of app-based, video check-in that a patient does that we combine both their self-reported progress against kind of discharge protocol with the signal that we're getting from them to identify earlier patients more likely to return to the hospital so that we can have some type of intervention activity. So I think the value of the Affectiva signal is kind of scale processing of the human element of patient care provider interaction. And so the more that we can get a signal on patients giving information that might signal a change in their state or a likelihood to have a worsened health condition, that drives better health for patients and better economics for the healthcare system.
That's awesome. Great. Well, thank you so much, Dave. It was a pleasure to have you. We will definitely talk more about how we can collaborate deeper, but thanks for joining us today.
Sounds good. Have a great conference. Thanks for your time.